Good morning. This is the first of a series of 3 lectures on liver diseases. In the first one, we will go together on how we recognize the presence of liver disease based on the history, the physical exam, imaging, and interpretation of liver function tests. And in the second lecture, I will be discussing acute and chronic hepatitis. And the third one will be on liver cirrhosis and its complications. The lecture on liver cirrhosis is given by Dr. Fadi Francis. I will be adding a few slides to it and I will be updating it. And I will be given the TBL on liver cirrhosis. So in this first VOP, I'd like you to become familiar with the tools we have to recognize or diagnose the presence of liver disease. As I mentioned before, we will be emphasizing the history, the physical exam, laboratory tests, and imaging. There will be focus and emphasis on how to interpret liver function tests, and then how to understand how liver disease affects the metabolism of carbohydrates, lipids, and protein. And finally, I'd like you to start to familiarize yourself with what we call steatotic liver disease or fatty liver disease. The old name is fatty liver disease. The new name is steatotic liver disease. So I will be focusing on how we recognize the presence of liver disease when we have a patient encounter. And we depend heavily on the history and the physical exam. And those, of course, may be supported by laboratory tests and imaging studies, and rarely nowadays liver histopathology. And I will be leaving that part of liver histopathology to Dr. Ayman Tawil. Now, in terms of the history, we focus on risk factors for liver disease, such as ethanol misuse, IV drug abuse, sexual promiscuity, family history of liver disease, etc. And we focus also on symptoms of liver disease, and the most important one would be fatigue, which is obviously not a specific symptom for liver disease, but some symptoms may be more specific, such as right upper quadrant pain, jaundice, tea-colored urine, clay-colored stools, etc. And also, I will be showing you some physical findings that should suggest the presence of liver disease that will be coming later in this presentation. We will learn how to interpret liver function tests and how to monitor the patients with liver disease through monitoring of liver function tests. This slide shows the multitude of physical findings that could possibly be present in patients with advanced liver disease. I will divide them into physical findings related to portal hypertension, namely splenomegaly, ascites, as well as the caput medusa. There are also what we call stigmata of chronic liver disease, such as spider angiomas, as well as pulmonary erythema. There is the feminization syndrome findings in patients, in male patients, what we call the female Eustachian mainly testicular atrophy and gynecomastia. And there are also findings related to advanced liver disease, namely jaundice, scleral icterus, as well as proximal muscle wasting. This slide shows scleral icterus or jaundice. It is defined as yellowish discoloration of the skin and mucous membranes. It is seen earliest in the sclera, in the eardrums, as well as on the frenulum of the tongue. And the reason for their early appearance there is that those tissues are rich in elastin, which has very high affinity for bilirubin. Jaundice means hyperbilirubinemia. Normal serum bilirubin is below 1 milligram per deciliter, and you start seeing scleral icterus when the level goes to around 2.5 milligrams per deciliter, or, of course, if it is higher. Here we see three main physical findings. One is massive ascites. The abdomen is protuberant and is full of fluid. We also see an umbilical hernia, which is secondary to massive increase in intra-abdominal pressure because of the ascites. And we also see a web of veins on the abdominal wall, what we call the caput medusa. The three findings are related to portal hypertension, which we will be discussing as we go by. Here we see two findings. One is palmar erythema, which is reddish discoloration of the skin along the thenar and hypothenar eminences in the hands, as well as the fingertips. And we see what we call Dupuytren's contracture, which is fibrosis of the fascia of the palms of the hands in patients with cirrhosis, typically alcoholic cirrhosis. So palmar erythema in men should always raise suspicion of chronic liver disease. In women, it may be due to a hyperestrogenic state, such as in pregnancy. So in women, it does not have to mean the presence of liver disease, but in men, it should force you to look for liver disease. And here is another photograph taken actually from Harrison's textbook of medicine, showing very nicely the palmar erythema on the thenar and hypothenar eminences, as well as on the fingers of a patient with advanced cirrhosis. You can never forget such a scene. And when you see it, when you look for it on physical examination in a patient, particularly a male patient, and you inform them that this could be related to a liver problem, you really impress your patients, and you can find evidence of liver disease later on. Clubbing of the fingernails is another finding that could be related to advanced cirrhosis. We also see it in patients with advanced pulmonary disease and right to left shunt and chronic hypoxemia. We see it in patients with advanced pulmonary hypertension, and we can see it sometimes in patients with malignancies such as lung cancer or other tumors. So it is not specific for advanced liver disease, but when you see it, you should look for those possibilities, including the possibility of liver disease. The presence of teres nails may be due to liver cirrhosis. what you can see on the slides, which I obtained from Google Images, they are very nice, is whitish discoloration of the nail bed, loss of the lunulae, which is at the bottom of your nail, pointed to by C, and purplish discoloration of your nail tip. The three findings are due to diminished vascularity of the nail bed and to deposition of connective tissue there. It is not specific for chronic liver disease or cirrhosis. It can be seen in heart failure, renal failure, or diabetes, but when you see it, you have to consider the presence of liver disease as one possibility. This patient has multiple physical findings of advanced liver disease. One is proximal muscle wasting. Look at this man's muscles in the left arm. They are wasted. The patient also has gynecomastia, which is part of the feminization syndrome we see in males with advanced liver disease. He also has evident ascites as well as an umbilical hernia. Here we see an example of spider angiomas, which are flat vascular structures that are present usually on the upper part of the torso, on the face, on the proximal part of the upper extremities. They are composed of a central arteriole and a web of vessels converging on that central arteriole or emanating from that central arteriole. So the appearance is rather typical. If you take a pencil and press on the central arteriole, you will blanch the whole structure. Spider angiomas in men would be quite suggestive of advanced liver disease. In women, they could be present as a result of the excess estrogen or hyperestrogenic state, particularly in pregnancy. If you find more than 3 to 4 spider angiomas in a woman, you also need to look for the possibility of liver disease. In men, you should always look for liver disease if the patient has spider angiomas. And here is another photograph taken from Harrison showing multiple spider nevi. The one in the center of the picture is a classical one. You will see the central arteriole and the vascular branches emanating from it, and you will see that it is a flat structure. After the history and the physical examination, we will discuss now the interpretation of liver function tests. Those tests are used to detect the presence of liver disease, to help us determine the type of liver disease. Is it hepatocellular injury, or is it cholestatic injury, or is it a mixed injury? The liver tests help us also determine the severity or extent of liver disease, and also they can be very useful in following up the response to treatment of multiple liver diseases. Among the most commonly ordered tests are the transaminases or the aminotransferases. There are 2 enzymes. One is called the ALT or SGPT, which is present in the cytosol, mostly in the liver. And one is called the AST or SGOT, which is present in the cytosol and mitochondria. And it is not as specific for the liver as the ALT.
because it's also present in the liver, in the heart, in the muscle, in the brain, and in the kidney. Normal values are less than 35 international units per liter. We do not know what brings those enzymes to serum. In other words, the source in normal people is not clear. So let's say you measure your ALT and you find it to be normal, 15, let's say, international units per liter. What is the source of that is not clear. Is it dying hepatocytes, apoptotic hepatocytes, etc.? We don't know that. Before we discuss etiology of increase in transaminases or aminotransferases, let me state first that an increase in transaminases generally reflects the presence of hepatocellular injury. For the sake of understanding, I have divided increases in transaminases into mild, meaning that the increase is to less than 5 times the upper limit of normal. So we're talking about an AST or ALT of 75, 100, 150, in that range. And severe, which we will cover in the next slide. So for mild increase in transaminases, I shall remind you first that the ALT is much more specific for liver injury. So the common hepatic causes of ALT predominant increase in level or mild increase in ALT, the common etiologies include steatosis, fatty liver, steatohepatitis, meaning non-alcoholic steatohepatitis, chronic hepatitis B, chronic hepatitis C, and drug intake. A large number of medications can cause liver injury, and I will be discussing this in 2 separate slides later on. If the increase is AST predominant, that is SGOT predominant, then you have to think of alcohol-related liver injury as well as of steatohepatitis, can do that, and liver cirrhosis. Remember that the AST or SGOT is not specific for the liver and is present in multiple other organs, and therefore it can increase in hemolysis, in muscle diseases, myopathy, in thyroid disease. It can increase also after strenuous exercise. Let me correct the definition of severe increase in transaminases, which is more than 15 times the upper limit of normal and not more than 10 times, as I mentioned before. The most common causes are acute viral hepatitis, A, B, C, D, or E, or even herpetic hepatitis, drug-induced hepatitis, ischemic hepatitis, and autoimmune hepatitis. Also, acute bile duct obstruction, which is common, which causes a massive acute increase in intrahepatic pressure, leading to hepatocyte necrosis and release of transaminases into the circulation. This is usually associated with severe upper abdominal pain, and the rise in transaminases is transient. It lasts 1 or 2 days. In viral hepatitis, on the other hand, there is minimal discomfort, and the rise in transaminases goes on for weeks. We come now to the alkaline phosphatase, another liver enzyme. The alkaline phosphatase hydrolyzes phosphate esters. I don't require that you remember what the alkaline phosphatase does. It is present in the liver, in the microvilli of bile canaliculi, and on the canalicular membrane of hepatocytes. It is also present in non-hepatic tissues such as bone, intestine, and the placenta. Another important enzyme is gamma-glutamyl transpeptidase, or gamma-GT. This enzyme transfers gamma-glutamyl groups from peptides, such as glutathione, to amino acids. Again, I do not want you to remember that function. The gamma-GT is present in hepatobiliary tissue and in other tissues, but not in bone. So that would be an important point to distinguish it from, to distinguish an increase in alkaline phosphatase that is due to bone disease versus liver disease. Now, let me repeat that. If a patient has a substantial increase in the alkaline phosphatase, but the gamma GT is strictly normal, then you have to look for non-hepatic disease, because in hepatic diseases, they go up together. So this is an important point for you to remember. But also the gamma GT is not 100% specific for the liver. It's present in pancreatic tissue, in the heart, in the kidney, and in the lungs. One thing we know about gamma GT is that its synthesis is induced by ethanol intake. So if people misuse alcohol, that can lead to an increase in gamma GT, even in the absence of detectable liver disease.
The alkaline phosphatase and gamma GT are increased in cholestatic conditions. And I remind you that cholestasis is defined as failure to secrete bile. That clinically manifests as itching and fatigue. And the problem could be anywhere from the canalicular membrane of hepatocytes to the ampulla of Vater. Any obstruction or impairment of bile secretion along that pathway can lead to cholestasis and an increase in alkaline phosphatase and gamma GT. So cholestatic conditions. In this case, the transaminases, meaning the ALT and AST, will typically be normal, and if anything, they could be very mildly increased. But the predominant problem in patients with cholestasis is increase in the alkaline phosphatase and gamma GT. Also, the alkaline phosphatase and gamma GT are increased in infiltrative conditions. So if the liver is infiltrated by granulomas, such as in sarcoidosis or tuberculosis, then the alkaline phosphatase and the gamma GT will be increased. Also, if the liver is infiltrated by tumor, metastatic disease to the liver, the alkaline phosphatase and the gamma GT will be increased.
Now we come to bilirubin metabolism. This is an extremely important concept for the understanding of jaundice. Bilirubin is the end product of heme metabolism. Heme is a component of hemoglobin, as you know, and the rate-limiting step in the synthesis of bilirubin is heme oxygenase. This reaction takes place mostly in reticuloendothelial cells wherever they are present, such as in the bone marrow, in the spleen, etc. The bilirubin that is generated by this reaction is called indirect bilirubin or unconjugated bilirubin. It is not water soluble, and therefore it is not filtered by the kidney, and it is transported in serum bound to albumin. This is a very important concept for you to understand. So bilirubin that is generated in RE cells is carried in serum bound to albumin, shown here on the extreme left of the slide is bilirubin bound to albumin before it enters the cell from the sinusoid, i.e. from the blood. So bilirubin enters the hepatocyte where it is conjugated by an all-important enzyme called UDP transferase, which is present in the smooth endoplasmic reticulum. And you generate from that reaction conjugated bilirubin, either bilirubin monoglucuronide or more likely bilirubin diglucuronide. The two of them are water soluble, and therefore thereafter they are secreted across the canalicular membrane of the hepatocyte as a component of bile. Bilirubin is the pigment of bile, and it is what gives bile its dark green color. In the intestine, bilirubin, conjugated bilirubin, is acted on further to become urobilinogen, which is absorbed across the intestine into the bloodstream and which is filtered by the kidney and metabolized into urobilin. Urobilin in urine is what gives urine its yellowish color. Whatever is left of bilirubin in the intestine or of urobilinogen is further metabolized by gut bacteria into stercobilin, and stercobilin is what gives your stools their brown color. So here are two diagrams. The one on the left is that of unconjugated bilirubin, which I repeat is not water soluble and is transported in serum bound to a protein bound to albumin. And on the right is conjugated bilirubin bound to two molecules of glucuronide. Conjugated bilirubin, on the other hand, is water soluble, does not need to be transported bound to a protein, and can easily be filtered by the kidney. You do not need to remember those formulas. It's just you need to understand the difference between unconjugated or indirect bilirubin and conjugated or direct bilirubin. So if you do an HPLC on bilirubin in serum, shown in the middle of the slide, most of bilirubin in serum is unconjugated. That is the bilirubin you generate in RE cells, while most bilirubin in bile, shown on the extreme left of the slide, is the conjugated bilirubin. If you measure your own serum bilirubin, it's typically less than 1 milligrams per deciliter, and the conjugated component in serum would be less than 0.3 or 0.2 milligrams per deciliter. So most of your bilirubin in serum is of the unconjugated type. So what are some of the etiologies of jaundice that you may be aware of, or that you should be aware of? That would depend on the population that you are studying. Let me remind you first that jaundice is yellowish discoloration of the skin and mucous membranes, and that it is seen when serum bilirubin goes above 2.5 milligrams per deciliter. In infants, the most common cause is physiologic jaundice of the newborn, and there are some other less common etiologies that you don't have to remember. In adolescents, on the other hand, Gilbert's syndrome, which I will be covering in a while, is the most common, followed by viral hepatitis. In young adults, on the other hand, viral hepatitis is the most common cause of jaundice, followed by alcohol misuse and biliary tract disease, meaning stones, tumors. Also, autoimmune disease becomes a common cause of jaundice. Rarely, a malignancy may be a cause of jaundice in the young adults. In the elderly, however, the most common cause of jaundice is malignancy, followed by drug or toxin-induced hepatic injury and autoimmune disease, as well as biliary stones. Viral hepatitis becomes much less common in the elderly. In your approach to a patient with jaundice, your most important tool is the history and the physical examination. You will need to supplement that with some laboratory tests and imaging studies, and rarely, very rarely, a liver biopsy.
We will be covering several types or patterns of liver diseases or liver injury. As we go by, we will cover acute hepatocellular injury as exemplified by acute viral hepatitis. We will also cover chronic hepatocellular injury as exemplified by chronic viral hepatitis. We will discuss also infiltrative diseases. The most important one is steatotic liver disease. This is a very important one. The old name for steatotic liver disease, if you come across it, is non-alcoholic fatty liver disease. I just keep mentioning the old name because you might come across it and you need to recognize what that is. We will also cover some cholestatic diseases. I remind you that cholestasis is failure to secrete bile. The failure to secrete bile could be due to an obstruction anywhere along the biliary tree, such as secondary to a tumor or a stone. We call that obstructive cholestasis. Or it could be due to non-obstructive cholestasis. You can have failure to secrete bile secondary to, for example, medications. An example would be estrogens. They can cause cholestasis even though you have no obstruction of the biliary tree. They cause failure to secrete bile. This slide covers an extremely important concept about a common and important liver disease, that is steatotic liver disease. It is defined as the excess accumulation of fat in the liver, either triglyceride or fatty acids, in more than 5% of hepatocytes. It is an example of an infiltrative disease of the liver. It is usually due to an imbalance between what enters the hepatocyte as fat and what leaves the hepatocytes as fat. So if more fat enters the hepatocyte, or if the hepatocytes makes more fat, or if the hepatocyte is not able to secrete its fat, then you will end up with fat accumulation in the liver, the so-called steatotic liver. fatty liver. The old name is fatty liver. It is generally divided into two types, what we call the large fat droplet accumulation or macrovesicular steatosis, which is typically seen in patients with metabolic dysfunction, namely obesity, malnutrition, diabetes, but it also can be seen in patients who misuse alcohol, the so-called alcoholic liver disease. The second type is small fat droplet accumulation, which is microvesicular steatosis. It is seen in pregnancy in the third trimester. We call it acute fatty liver of pregnancy. We see it in patients who develop Reye's syndrome. This is typically a condition that children develop when they have influenza and when they take aspirin to bring down their temperature. They could develop microvesicular steatosis, and it is seen sometimes secondary to medications such as tetracycline and valproic acid. Microvesicular steatosis is usually an acute, potentially life-threatening emergency that could lead to acute hepatic failure. Let me further emphasize the extreme importance of steatotic liver disease. Now we give it the general name called metabolic dysfunction associated steatotic liver disease. It is very common. It affects about 30% of the population. It is defined again as the accumulation of fat in more than 5% of hepatocytes, or when fat constitutes about 5% or more of liver weight. It is the most common cause of mild increase in liver enzymes. It is often asymptomatic, does not cause any symptoms. In some patients, about 10% of patients with metabolic syndrome associated steatotic liver disease, the fat accumulation is associated with necroinflammatory activity. That is, there will be associated inflammation in the liver, which might progress to liver fibrosis and ultimately to liver cirrhosis and hepatocellular carcinoma. So metabolic syndrome associated steatotic liver disease might lead to metabolic syndrome associated steatohepatitis, MASH, inflammation in the liver, and that can lead to fibrosis, to cirrhosis, and to hepatocellular cancer. You can tell that this is not a benign entity, that it has to be taken seriously and it has to be recognized and treated. We call it metabolic syndrome associated steatotic liver disease because it is associated with the metabolic syndrome, which is characterized by abdominal obesity, hyperlipidemia, hypertension, etc. Metabolic syndrome associated steatotic liver disease or metabolic syndrome associated steatohepatitis is also a marker for the presence of diabetes, hypertension, and vascular disease. When people develop it, they are at risk of getting hypertension, diabetes, and vascular disease, and patients have to be informed about that.
We discussed before the derangements of lipid metabolism in patients with fatty liver disease. Now we will discuss what happens to carbohydrate metabolism. We mentioned that the liver is the organ that maintains your blood glucose in the post-absorptive state via glycogenolysis and gluconeogenesis. This is a very important process that avails glucose to your brain, your most vital organ, when you are fasting. There are two possible consequences of liver diseases on carbohydrate metabolism. The first one is hypoglycemia. We can see that in acute hepatitis, particularly in fulminant hepatitis, when simply there would be not enough hepatocytes or not enough hepatocytes to do gluconeogenesis and glycogenolysis. And we see it also in patients with alcoholic liver disease, particularly those who are dependent on alcohol as a source of calories. On the other hand, we can see glucose intolerance and secondary diabetes in patients with chronic liver disease and cirrhosis. We do not fully understand the mechanism of this secondary diabetes, but we think it is due to insulin resistance at the receptor or post-receptor level in patients. Let me address isolated unconjugated hyperbilirubinemia. There are three examples here. The first one is Gilbert's syndrome, which is an inherited condition. It affects about 5% of people, and it is characterized by episodes of jaundice. And it gets worse with fasting and after viral illnesses. And all other liver functions and liver imaging are completely normal. And the prognosis is excellent. There is no effect on mortality in this case. The second example is hemolysis, in which you break down large numbers of red cells and you generate a lot of heme, and therefore you generate a lot of unconjugated bilirubin. Transfusions also can cause unconjugated hyperbilirubinemia by the same mechanism. With unconjugated hyperbilirubinemia, you are not expected to have tea-colored urine, as unconjugated bilirubin is not water-soluble and is bound to albumin. Gilbert's syndrome is autosomal dominant. As I said, it is characterized by episodic jaundice with a serum bilirubin going up to 4, 5, or 6 milligrams per deciliter. Everything else related to the liver is completely normal, and the prognosis is excellent and normal. The pathophysiology seems to be impaired entry of unconjugated bilirubin across the sinusoidal membrane of the hepatocyte, and a mild impairment of conjugation inside the hepatocyte. A much less common syndrome is Crigler-Najjar syndrome, which is characterized by mutations in UDP transferase, which is the enzyme that conjugates bilirubin. The mutations could result in total absence of the enzyme, which we call type 1, which is incompatible with life, or it can be associated with a reduced function of the enzyme, which is type 2. The result would be a massive increase in serum unconjugated bilirubin, which could go up to 20 or 25 milligrams per deciliter. Because the blood-brain barrier in neonates is not completely developed, unconjugated bilirubin can cross, and it is a toxin and can cause severe nervous system damage, a condition which we call kernicterus. This condition has to be treated, and it's typically treated by phototherapy, which can transform unconjugated bilirubin into a water-soluble form, or by giving drugs which induce the synthesis of UDP transferase, such as phenobarbital.
An example of isolated conjugated hyperbilirubinemia, that is an increase in conjugated or direct bilirubin in serum, is Dubin-Johnson syndrome. This is another rare inherited disorder that is characterized by a defective carrier of conjugated bilirubin at the canalicular membrane of hepatocytes. This is an inherited condition characterized by episodes of jaundice secondary to increase in conjugated bilirubin this time, and by T-colored urine, because conjugated bilirubin is water soluble and is able to cross the kidney into urine. All other liver functions are completely normal and the prognosis is excellent. This is a disorder, a pure disorder of bilirubin metabolism. This slide, which I have taken from Harrison, shows the carrier of conjugated bilirubin across the canalicular membrane of hepatocytes. This carrier is called MRP2. This MRP2 is mutated, is defective in patients with Dubin-Johnson syndrome. That's why they're not able to fully secrete conjugated bilirubin across the canalicular membrane of hepatocytes. Again, I remind you, episodes of jaundice secondary to conjugated hyperbilirubinemia and T-colored urine. All other liver functions are completely normal.
This slide explains what happens when you have sudden obstruction of the common bile duct by a stone. You get what we call a biliary colic with severe upper abdominal pain, vomiting, and a sudden increase in transaminases because of acute increase in intrahepatic pressure, resulting in massive release of transaminases into the circulation. This is usually a transient increase in transaminases, but they could go up quite well into 500, 1,000, or something like that. Then they will come down very quickly, and they will be followed by a rise in alkaline phosphatase and conjugated bilirubin if the obstruction is not relieved. If you get with that fever, that is cholangitis, bacterial cholangitis, which is a very serious condition. The treatment of bacterial cholangitis, in addition to antibiotics, is to relieve immediately the obstruction, and we can do that. Dr. Sharara will discuss that. If you have, on the other hand, chronic biliary obstruction, such as by a tumor, you will have obstructive cholestasis characterized by itching, fatigue, and the liver tests will show mainly an increase in alkaline phosphatase and gamma-glutamyl transpeptidase and conjugated bilirubin. The transaminases will be either normal or very mildly increased. Now, if you have evidence of cholestasis, meaning that the patient has pruritus and fatigue, and increase in the alkaline phosphatase, gamma-glutamyl transpeptidase, and conjugated bilirubin, but there is no obstruction, meaning that the imaging of the liver is normal, you have to think of what we call intrahepatic cholestasis, and one of the most common causes is drug-induced cholestasis. Some of the medications that can do that are listed on this slide: phenothiazines, oral contraceptives, and erythromycin. The itching can be very nasty, and the patient can have excoriations on their skin from itching. The treatment, if it is drug-induced cholestasis, is to stop the inciting drug. Here is an example of obstructive cholestasis caused by a cancer involving the head of the pancreas and impinging and obstructing the distal common bile duct, resulting in obstructive cholestasis. The patient will have abdominal pain radiating to the back, and severe weight loss, and the survival, as you know, is very, very short. This is one of the terrible cancers. The liver tests will show cholestasis, i.e. increased alkaline phosphatase, increased gamma-glutamyl transpeptidase, increased conjugated bilirubin. The patient will also have tea-colored urine.
This CT scan shows an example of a common cause of obstructive cholestasis, which is pancreatic cancer. On the right side of the slide, in the upper left, there is a mass there, which is the pancreatic cancer. And on the left side of the slide, you see a massively dilated gallbladder. We call it Courvoisier's sign. The gallbladder is dilated because the biliary tree is obstructed. You can feel that dilated gallbladder on physical exam. I remind you that a normal gallbladder is not felt on physical exam. You can see also dilatation of the pancreatic duct in the middle of the pancreas. So pancreatic cancer can cause upper abdominal pain radiating to the back. It is associated with weight loss. It has a terrible prognosis. It's one of the worst cancers to have. The survival, as shown in the figure, is very poor. So this is an example of an obstructive cholestasis. Here, failure to secrete bile is due to a mechanical obstruction of the biliary tree by the tumor.
Jaundice can also result from tumors involving the liver or the biliary tree. In the case of metastasis to the liver, this is a pattern of infiltrative disease by tumors causing a high alkaline phosphatase, gamma GT, and conjugated bilirubin. The other examples shown in the slide include malignant lymph nodes, cholangiocarcinoma, ampullary cancer, or gallbladder tumor, all ultimately resulting in obstruction of the biliary tree and obstructive cholestasis with high alkaline phosphatase, gamma GT, and conjugated bilirubin.
Bile, or سائل الصفراء in Arabic, is composed of water and of solutes, which are the solid component of bile. The most important solute is bile acids themselves, which constitute about 2/3 of the solutes in bile. The rest is lipids, phospholipids, cholesterol, electrolytes, and protein. And there is a small fraction, 2%, that is bilirubin. Bilirubin is the pigment of bile. It's what gives bile its dark yellow or green color. Now, as you know, gallbladder bile is more concentrated than hepatic bile. The gallbladder concentrates bile. So in gallbladder bile, solutes are about 10% of bile, while in hepatic bile they're about 4%.
Bile acids are synthesized from cholesterol, and the rate-limiting step in that synthesis is an enzyme called 7-alpha hydroxylase. You initially make what we call primary bile acids, which are cholic acid and chenodeoxycholic acid, and you secrete them as part of the solutes in bile. They reach the intestine and they undergo 7-alpha dehydroxylation by intestinal bacteria to become the secondary bile acids. So cholic acid becomes deoxycholic acid, and chenodeoxycholic acid becomes litocholic acid. Please do not focus on the 27-alpha hydroxylase. And why do we care about bile? Because bile is involved in a multitude of vital functions. One of the most important ones is the enhancement of intestinal absorption of lipids, calcium, and iron. And this is by virtue of the fact that bile acids or bile salts are amphipathic molecules. That is, they have a water-soluble component as well as a lipid-soluble component. And hence, they are able to micellarize lipids that you take in your diet, forming micelles that can cross then the intestinal membranes into the ultimately the systemic circulation. And also, bile serves to get rid or excrete solutes that are poorly filtered by the kidney because they are not water soluble. So these include cholesterol itself, bilirubin, and whatever your body ingests that can be toxic and that cannot be filtered by the kidney. Also, you secrete some trace minerals in bile, such as copper, which is extremely important because in patients who are not able to excrete copper in bile, and those are patients with Wilson's disease, al-marad al-nuhasi, copper accumulates in the liver and ultimately in the whole body, leading to severe liver damage, central nervous system damage, and death if it is not treated. Also, bile serves to excrete antigen-antibody complexes and immunoglobulin A, which is vital in intestinal immunity. So bile is involved in a multitude of vital functions to the body.
Bile salts are very precious molecules, and the body has designed a system to preserve them and to reduce the need for new synthesis. In summary, bile salts, which are made inside the hepatocytes, are secreted across the canalicular membrane of hepatocytes into the biliary tree. Bile salts reach the intestine. They carry their function that I mentioned before. They are modified by intestinal bacteria into secondary bile salts. Then they are absorbed from the terminal ileum, which is an active process. They're absorbed into the portal circulation and back into the liver. They are absorbed across the sinusoidal membrane of hepatocytes. And thus for this process to happen, we have three active processes. The first one I mentioned, secretion of bile salts across the canalicular membrane of hepatocytes. That's an active one. The second one is absorption from the terminal ileum back into the portal circulation, and that's also an active one. And the third one is reuptake into the liver across the sinusoidal membrane of hepatocytes, and that's also an active one. You of course lose a little bit of bile salts in the stools, about 600 milligrams daily, and you need to synthesize, of course, about 600 milligrams daily. That whole process is called the enterohepatic circulation of conjugated bile acids.
Cholestasis is reduced bile flow or failure to secrete bile. Clinically, it manifests as itching and fatigue. Biochemically, there is increased alkaline phosphatase, gamma GT, and conjugated bilirubin, and therefore there will be also tea-colored urine. It can be intrahepatic, secondary to a problem at the canalicular membrane of hepatocytes, such as secondary to medications, such as oral contraceptives. It can also happen in pregnancy, or it can be due to an autoimmune disease involving the bile ductules, which we call primary biliary cholangitis. It can also result from obstruction of the biliary tree, which we call obstructive cholestasis. That can be due to stones or tumors involving the biliary tree itself, the ampulla of Vater, the gallbladder, or the head of the pancreas. In those cases, the biliary tree is obstructed and therefore it will be dilated, and that can be detected by imaging such as ultrasound, CT scan, MRI, or ERCP.
So whenever you encounter a patient with cholestasis, i.e. itching, jaundice, decolored urine, fatigue, and that person has increased conjugated bilirubin, increased alkaline phosphatase, and increased gamma GT, this is a cholestatic condition. You have to define first if there is an anatomical problem such as obstruction of the biliary tree, as I mentioned before. So you need to image the biliary tree by ultrasound, CT scan, MRI, and find out if the biliary tree is obstructed. And the hallmark of biliary tree obstruction is the presence of a dilated biliary tree. A biliary tree that is obstructed will dilate. So if there is an anatomical problem, then you need to define it further. Is it a stone? Is it a tumor? Is it a stricture, etc.? If you find out that the biliary tree is normal, it is not dilated, and the liver appears normal, then you know you are dealing with intrahepatic cholestasis. That can be due to a medication such as oral contraceptives. It can be due to sepsis. It can be due to total parenteral nutrition, or it can be due to the autoimmune condition I mentioned before, primary biliary cholangitis.
The liver is responsible for the synthesis of a wide array of proteins such as albumin, prothrombin, and fibrinogen. In extensive chronic liver disease, there is hypoproteinemia and hypoalbuminemia, and therefore there is reduced oncotic pressure and interstitial edema. However, it takes a lot of time for serum protein to go down because albumin has a half-life of about 20 days. And therefore, serum protein may be normal in a patient with acute severe liver disease. Furthermore, hypoproteinemia is not specific for liver disease. It can be due to malnutrition or to reduced absorption of proteins from the small intestine, such as celiac disease, or to wasting of proteins in the urine, such as in nephrotic syndrome. The normal level of serum albumin is between 33, 34 to 55 grams per liter. As I said, albumin has a long half-life, and therefore serum albumin may be completely normal in somebody with acute severe liver injury. You cannot say that a patient with acute liver disease who has normal serum albumin, that patient has mild injury. The injury could be quite severe and serum albumin could be quite normal.
All your clotting factors, except for factor 8, are made in the liver. Factor 8, as you know, or von Willebrand factor, is made by endothelial cells in your blood vessels. Now, one way of measuring the availability of clotting factors is a test called the prothrombin time, which is basically the time it takes for your blood to clot in a test tube to transform prothrombin into thrombin. It's usually in the order of 10 to 12 seconds, and we usually compare it to a control which is normal. The rate limiting step or factor, the rate limiting factor in that reaction, clotting reaction, is factor 7, which has a half-life of about 5 to 6 hours. And therefore, the prothrombin time is a sensitive indicator of severity of acute liver injury. So if somebody has acute hepatitis and the prothrombin time becomes very prolonged, that usually indicates severe acute hepatitis to the point of making clotting factors not available. They will become not available so quickly because their half-life is very short. Also, the prothrombin time is prolonged in patients with advanced chronic liver disease, advanced liver cirrhosis. So unlike serum albumin, albumin can be normal in acute severe liver injury. The prothrombin time will be prolonged in acute severe liver injury. Albumin will be low in patients with chronic advanced liver disease, such as chronic liver cirrhosis. Okay, thank you.
Ammonia is the end product of amino acid metabolism. It is an endogenous toxin, and it's gotten rid of through the urea cycle in the liver. Urea can be excreted in the kidney. Ammonia level is elevated in patients with liver disease, particularly liver cirrhosis, and it is also elevated in patients with portal hypertension as ammonia is absorbed and diverted from the liver through portosystemic collaterals that we talked about before. Ammonia is a toxin. It can cause dysfunction of astrocytes in the brain and other things, leading to what we call hepatic encephalopathy, which is a set of neuropsychiatric abnormalities that happen in patients with liver disease. This is an extremely important molecule, and treatment of hepatic encephalopathy will be discussed by my colleague, Dr. Fadi Francis. Here is a summary of how to interpret liver function tests. The ALT and AST usually reflect hepatocellular damage, and depending on whether the increase is mild or severe, you should consider viral hepatitis, autoimmune hepatitis, drug-induced hepatitis, or non-alcoholic steatohepatitis. Bilirubin can be increased in cholestasis, as mentioned before. It can be increased in pure disorders of bilirubin metabolism, such as Crigler-Najjar or Rubin-Johnson syndrome, as I mentioned before, and it will be increased also in biliary obstruction. Both the alkaline phosphatase and the gamma GT are increased in cholestasis, and they are increased in infiltrative disease, such as when the liver is infiltrated by malignant metastasis. Both will be increased also in biliary obstruction. The albumin and the prothrombin time reflect synthetic function. So in patients with advanced liver cirrhosis, albumin level will be low. In patients with acute severe hepatic dysfunction, such as fulminant hepatitis, and in patients with cirrhosis, the prothrombin time will be prolonged. And that's also a reflection on synthetic function. The bile acids are increased in cholestasis, such as cholestasis of pregnancy. Here is a reverse way of looking at it. That is, I will give you examples of diseases and what you would expect in terms of liver function abnormalities. In patients with hemolysis, all liver tests will be normal, and the only thing that will be increased is indirect bilirubin, unconjugated bilirubin. In patients with acute hepatocellular necrosis, such as acute viral hepatitis, drug-induced hepatitis, the predominant pattern will be a marked increase in transaminases, AST and ALT. All types of acute liver injury have a little bit of cholestasis. So there will be some elevation of conjugated bilirubin, some elevation of alkaline phosphatase, and some elevation of gamma GT. The synthetic function in acute injury, as I said before, will be normal. The prothrombin time, unless the acute injury is very severe or fulminant, will be also normal. In patients with chronic liver disease, cirrhosis, synthetic function will be abnormal. Albumin will be low. The globulins will be elevated. The prothrombin time will be prolonged. Bilirubin could be prolonged. and there will be mild elevation of transaminases. In cholestasis, on the other hand, whether it is intrahepatic, extrahepatic, or infiltrative, the predominant pattern will be an increase in the alkaline phosphatase and gamma GT. The conjugated bilirubin will be increased in cholestasis. It might be normal in infiltrative diseases. The globulins may be normal or increased in infiltrative diseases. Drug-induced liver injury, or DILI, is common, and no assessment of patients with liver dysfunction can be complete without a detailed drug history. Drugs can cause a viral hepatitis-like picture. An example would be the anesthetic halothane and the anti-tuberculous medication isoniazid, or INH. They can cause mild cholestasis, such as estrogens present in oral contraceptives. They can cause inflammatory cholestasis, meaning cholestasis, as you know it, in addition to inflammation, fever, leukocytosis, arthralgias, etc. Examples would be phenothiazines, augmentin, and erythromycin. They can cause ductopenic cholestasis, meaning they can cause obliteration of the bile ductules inside the liver with cholestasis. Examples would be tricyclic antidepressants and carbamazine. Nobody knows all the possible reactions or effects of drugs on the liver, so we often consult a very useful website called LiverTox. The address is www.livertox.org, and it has all the information you can require or you need about the possible drug-induced liver injury. Drugs can also cause fatty liver. Examples would be tetracycline, valproic acid, antiretroviral drugs, and protease inhibitors used in HIV therapy. And not listed here is tamoxifen, which is used in patients with breast cancer. Fatty liver, if it's of the microvesicular type, can be quite serious and can lead to hepatic failure. They can also cause cirrhosis. An example would be methotrexate. They can cause portal hypertension, such as vitamin A. They can cause disseminated granulomas in the liver, such as sulfonamides, and they can cause veno-occlusive disease. An example would be high-dose chemotherapy, which can injure the sinusoidal cells and cause veno-occlusive disease.
Artificial intelligence is transforming hepatology, and no discussion of diagnosis or diagnostics in liver disease will be complete without referring to the growing role of artificial intelligence. Very briefly, AI seems to be very helpful, very promising in the detection and early diagnosis of metabolic dysfunction associated steatotic liver disease and steatotic hepatitis, alcoholic liver disease, viral hepatitis, autoimmune and cholestatic liver disease, drug-induced liver injury, and in the detection and early diagnosis of liver tumors, hepatocellular carcinoma and cholangiocarcinoma. This is already in multiple hepatology societies guidelines. It is becoming part of practice in the modern world.